and she's the lead author of their newest publication, Taking Action for Women's Health, Practical Strategies to Mobilize for Change. She's also served on 2 curriculum task forces for the Dell Medical School and serves as chair of the Physician Advisory Board of the Integrated Care Collaboration, and she's co-founder of the East Austin Community Health Promoters Project. In 2002, she was very deservedly awarded the University of Washington School of Medicine's Alumni Humanitarian Award. Please join me in welcoming Dr. Melissa Smith.
Can you hear me? I guess I should put this on. Thank you all for coming this afternoon and being here, and thank you so much for the really warm welcome to the School of Nursing. It is such a privilege to be with all of you and to be co-teaching with our fabulous Dr. Myung Kim, our graduate seminar. Truly a joy and really wonderful to be working with students and faculty here. So many, many thanks. I'm delighted to be able to share with you experiences and analysis of collaborative efforts to promote the health and rights of women and girls gathered over 3 decades of working in resource-poor communities. 2 stories from early in my professional life frame these experiences. I went to Liberia at the age of 20 to volunteer in a remote medical clinic to gain hands-on experience, hoping to clarify whether I wanted to go into the field of medicine. Soon after my arrival, I helped care for this 11-month-old girl named NJ, whose mother brought her on foot from their remote village, malnourished with diarrhea and dehydration. Like so many other poor communities in their world, their village lacked running water, electricity, schools, and any health resources. Concerned about the fluids draining from her child's body, NJ's mother thought it was best to not give her liquids in hopes of preventing the loss of even more fluids. Instead, as many people did in her community, she packed her infant's sunken fontanelle with moist earth with the belief that this would help. There ensued a struggle with the Western-trained Liberian nurse who worked at the clinic. She cut off the ambulance that had been placed by the village healer on Dendenje and her siblings, and scolded Dendenje's mother for her ignorance of how to care for her children. When the nurse placed the IV, weak cries filled the room and frightened Dendenje's mother even more. The next morning, we discovered that Dendenje's mother had removed the IV. Her beloved child died in my arms. This tragic loss of Dendenje's life set me on my own life's path and taught me 2 important principles. First, in remote communities where access to health care is limited, everyone needs access to information and care that can help keep them healthy. Second, this access to information and care are not enough. We must work together with people who bear the burden of health inequities to understand and address the root causes of the problems they face. In order to address these root causes, I learned that we need to promote community empowerment for health. I decided to study medicine in order to gain skills to offer people in need, but also to work in partnership with community members to support their efforts to take action on the underlying causes of poor health. This vignette from Liberia is echoed in the story of a whole country, Nicaragua, where I spent extended time in the 1980s in search of answers to these daunting health challenges. Like Liberia, Nicaragua was an impoverished country with high maternal and infant mortality rates. The Nicaraguan Revolution, for those of you who are not quite old enough to remember it, transformed the nation's health by training thousands of community members to provide basic life-saving information to people in remote areas with limited access to care, and to mobilize others to take action on the social determinants of health. After completing medical school, I spent a year working for the Department of Popular Health Education in Nicaragua's Ministry of Health, training community health workers and midwives in maternal child health. In addition to teaching these community leaders about solutions so common as oral rehydration methods, this program also gave them skills to participate in large-scale vaccination and malaria campaigns and public health efforts to build latrines and dig wells. We also train traditional midwives how to promote safe motherhood. These initiatives, coupled with work on other social and economic factors, including a national literacy campaign, as well as agrarian reform, brought dramatic improvements in health. In the first few years of these efforts, infant mortality in Nicaragua decreased by 33%. These two stories highlight the importance of making health information accessible and promoting community empowerment for health. Two principles which have echoed in many different ways since these early experiences in my professional life. I've continued to work as a family physician in resource-poor communities and have focused my global health work primarily on the needs of women and girls, who are so often the most vulnerable members of the communities in which I've worked. These women and girls, when organized, are powerful forces for change. Later today, I'd like to talk with you all about how insights and principles primarily drawn from experiences in resource-poor countries, often referred to as the Global South, relate to opportunities for collaborative efforts here in Central Texas. The concept of the Global South is not a geographic term, but instead it refers to marginalized communities anywhere in the world that face challenges because of a lack of power and resources. Poor and minority communities here in Central Texas, therefore, form part of the same Global South. In our efforts to promote global health equity, for example, community health initiatives in East Austin draw on insights from other resource-poor communities around the globe, and in turn offer new insights that may inspire others. No matter where we are on the globe, we can all learn from innovative strategies that improve people's health. Before talking about strategies to achieve these two principles, to make health information accessible and to promote community empowerment for health, it's helpful to briefly reflect on the context of health inequities from a global and a local perspective. Social inequities in health are dramatically represented in maternal mortality data, which remind us that throughout the world, poor and minority women bear the burden of disease. The fact that every 2 minutes a woman somewhere in the world is dying of pregnancy-related complications is alarming. That over 99% of these deaths occur in resource-poor countries is a call to action. But even in the United States, these disparities are cause for concern. The maternal mortality rate for African Americans here is 3 to 4 times the rate of whites. Disparities in infant mortality, so often influenced by maternal health, reveal similar patterns. The global rate of infant mortality is almost 6 times greater than the rate in the United States, and in Africa, that disparity is greater still. Within our own country, African American infants are twice as likely to die within their first year of life than whites. Unless we think that such inequities are somehow far removed, data from Travis County mirror these disturbing national disparities. African American women with college degrees have poorer birth outcomes than Anglo women who have not finished high school. What questions does this raise about how experiences of racial discrimination might play a role in these health disparities? When we learn that the daughters of African immigrants have worse birth outcomes than their mothers, we are reminded of that important question that we must ask about our society. Looking at children's health in general, as we can see in this graphic, it's so clear that as poverty increases, so does poor health. However, and I hope you can make out this somewhat busy graph, children who are African American or Hispanic at the same level of poverty have far worse health outcomes. Equity means social justice or fairness. If we want to achieve health equity, we need to promote institutional and social change that achieves equity in the power and resources that make up the social determinants of health, including education, housing, neighborhood safety, access to healthy food, transportation, and other factors. As you can see in this graphic from the Robert Wood Johnson Foundation, these broader social determinants of health account for 80% of the factors that influence health, while only 20% comes from the provision of health care. Because of this reality, my own professional path has shifted from focusing primarily on the practice of medicine to advancing efforts to promote health and social justice. But whatever professional path we choose, if we care about health equity, we must advocate for strategies and policies that promote economic, racial, and gender equity, all of which are critical to addressing health disparities. Considering this broader context, I will now explore strategies that can help achieve the two principles, making health information accessible and promoting community empowerment for health. Here are the three main ways we can make health information accessible to people in resource-poor communities. We need to make the information culturally appropriate and relevant. We need to make it free and universally available. And we need to use technology to reach people effectively. I will cover these three strategies one at a time. The first strategy, ensuring that materials are culturally appropriate and relevant to people's lives and have the right literacy level, requires working closely with community members who will use this information. I had the opportunity to help do this in the 1990s while working in Guatemala with a non-governmental organization that was directed by indigenous leaders whose mission was to train community health workers and midwives from remote communities. And in that time, they were providing 80% of the care around the country, simply those folks, because there weren't enough physicians to provide care. This organization, called the Association of Community Health Services, ASECSA, asked me to help them develop a reproductive health training program tailored to the needs and perspectives of diverse Mayan communities. These Mayan communities have been affected by very intense maternal and infant mortality and some of the highest rates in the hemisphere. Family planning and childbirth spacing are recognized as an important strategy to decrease both maternal and infant mortality. But in Guatemala, such initiatives face tremendous opposition. This program began at the tail end of a 36-year-long civil war, where there was devastating political violence that resulted in the loss of 200,000 lives. Because the United States had backed the Guatemalan army, which has since been held responsible for the majority of these deaths, communities mistrusted family planning programs, most of which were funded by USAID. This, coupled with knowledge of forced sterilization programs in other countries, raised concerns that family planning was simply another strategy to eliminate the Mayan population. Such distrust with an affirmation as well of Mayan traditions as well as other religious doctrines in Guatemala resulted in strong resistance to family planning. But because ASECSA was a well-respected organization and was led by Mayan workers, most of them except me, our efforts to advance this reproductive health program were remarkably well received. In addition to long-standing relationships and trust with the communities, ASECSA was responding to a need identified by many community health workers, midwives, and community members, young and old, who wanted access to birth control to either prevent or plan pregnancies and to decrease the number of women and infants dying. We worked closely with midwives and community health workers to develop this program, and in order to understand their perspective on the complex reproductive health barriers that women faced. One strategy that worked especially well for the midwives was to ask them to use modeling clay, and none of these midwives had the opportunity to go to school. Most of them were basically non-literate. But to ask them to use modeling clay to express to us how they understood human reproduction. And this way we laid the foundation for participatory methods to help them learn about reproduction and family planning, but really starting from their perspective. By using fruits and vegetables as models for human anatomy and creating narratives that were congruent with Mayan worldviews, they could easily explain to other people in their community how birth control works and could clarify and address the many myths that surrounded each method. And what was remarkable in this program is that men were as involved, if not more, than the women in doing this kind of education and consciousness raising. We tested all of our training content to make sure that the words and the literacy level were appropriate for the communities where we worked. We played a wonderful toss the yarn game where people would argue for and against family planning. One person would say, we can't use family planning because so many children are dying, so how can we limit this? And then someone else would say, but we know that if you space a pregnancy every 2 years, you can decrease the infant mortality rate by 50%. And so you'd see these arguments going back and forth, and it was a very effective way of people being able to go back to their communities and share the reasons and the benefits for family planning. This reproductive health guide that we developed and the training program is now being used by ASECSA throughout its regional training centers that are spread across the country. The second strategy to make health information accessible is to make it free and universally available. For the past 2 decades, I've served as a volunteer medical advisor and author, and I'm now a board member of Hesperian Health Guides, an organization whose mission is to promote health and empowerment in poor communities around the world. This collaboration has been influential in my thinking about the principles of making health information accessible and promoting community empowerment for health. Because of Hesperian's open access policy, community organizations download sections of our book for free from their website and translate them and adapt them into content in diverse global contexts. Since publishing Where There Is No Doctor, which, raise your hand if any of you have heard of this book. A few folks. Since publishing it in 1978, with 288 cumulative language translations of all of our materials to date, Hesperian has been told to be said by the World Health Organization to provide the most widely used public health manuals in the world. While I was working with ASECSA in Guatemala, I was asked by Hesperian to serve as the medical editor for Where Women Have No Doctor and to help field test it with community health workers and midwives. How many of you have heard of this book? All right. As part of Hesperian's hallmark collaborative book development process, we field tested this book in 40 countries, and since its publication in 1998, it's been translated into 41 languages. Hesperian's other women's health materials, which I've also helped develop, include a health handbook for women with disabilities, which is translated in 11 languages, and a book for midwives, which is translated in 16 languages. These are all freely available and widely used. Every year we receive letters from communities all around the world about how the information in these books has saved, or I should say helped and often saved, the lives of women and girls. And it's really incredible to to read these letters. They come in every month from all over, and they're very, very moving, and certainly inspire people like me to keep volunteering and doing this work. The third strategy to make health information accessible is to use technology to reach people effectively. This can be done by creating new technology that is available in multiple formats. We have dramatically expanded our capacity to do this in two ways. The first is with our Health Wiki digital platform, which was made possible some years ago by the Gates Foundation. This platform provides content in a wiki-based format, which is suitable for low or internet networks, like in communities in Nicaragua and Liberia and many other places where I've worked. Since we launched the Health Wiki in 2012, there have been a total of 5 million unique visits from people all over the world. And what's really incredible, in the last year, it's just grown exponentially. It's really remarkable. And what's even more remarkable is that most of the searches are for our women's health information. We've also used technology to reach people effectively through developing the Safe Pregnancy and Birth phone app, which is based on the low literacy information provided in our women's health books. As with all of our materials, we work with diverse community groups to field test this app, including Partners in Health, who field tested this in Chiapas and gave us wonderful feedback that it responds to the needs and literacy skills of the people who use it. They said that their midwives and health workers found it to be very easy to use and very relevant to the communities where they are. The Safe Pregnancy and Birth phone app is open source, which makes it freely available to communities and other nonprofit M-Health developers. It also has been widely used by people in 222 countries and territories, and it's won 2 international awards for providing innovative and effective solutions to promote the health and empowerment of women and girls. These diverse experiences and approaches are all examples of the main strategies to achieve the first principle of making health information accessible in resource-poor communities. However, when it comes to the health of women and girls, such efforts are not enough. We also need effective action towards community empowerment for women's health. Before I discuss the strategies to achieve this second principle, I would like to tell you about the path that has led to this insight and to developing these strategies. When we were field testing Where Women Have No Doctor in Guatemala, the indigenous midwives in that workshop said the information that we provided was very important, even life-saving, but that they needed something more. They needed strategies to raise awareness that the lives and health of women and girls mattered. They wanted to know how to organize and mobilize their communities to advocate for the health and rights of women and girls. The importance of this second principle, community empowerment for women's health, has been reinforced in my own experiences working as a doctor in poor communities, both in Central America and in the United States, and here in Austin. I think of an older woman with depression in Nicaragua who chronicled for me her years of experiencing domestic abuse. A married village woman in Guatemala seeking prenatal care for an unplanned pregnancy, already challenged to feed her 4 children. Or finally, caring for an adolescent girl in Austin who's been my patient for years, just diagnosed with her 2nd chlamydia infection. These recurrent stories are some of the reasons I have shifted my professional path. They remind us that in addition to offering women of all ages clinical and emotional help, as well as information, it is critical to partner with them and their communities to understand and address the root causes of their health problems. I've had the privilege of engaging in such efforts beyond my role as a physician and have seen transformative outcomes. These are some of the reasons why we wrote Health Actions for Women. This is a collective baby. This book responds to the feedback we receive from communities all over the world who've used our women's health books and, like the midwives in Guatemala, have asked for something more. This book project has been a labor of love and cooperation carried forward by a group of women devoted to making sure the world's poorest and most vulnerable women gain access to information and improve their quality of life. To create this resource, we brought together a steering committee of women health activists and trainers from South Asia, Africa, the Middle East, Latin America, and the United States to define a vision for this project. We gathered twice at the School of Advanced Research in Santa Fe to share the results of our research about training activities and strategies that communities around the world have used to work for change. We heard amazing, inspirational stories of women and girls taking action, overcoming challenges, and in partnership with men and boys, improving the health of their communities. We incorporated these ideas in chapters focused on priority women's health concerns. You can see them. And received important critical feedback from colleagues around the globe who work in diverse global contexts and have an incredibly broad range of expertise. We also field tested the chapters in this book, working with some 41 groups in 23 countries, from Cambodia to Mongolia, India to Kenya, Lebanon, Guatemala, and the United States. A total of 1,400 women and men of all ages, including adolescents, worked with us, field tested it, and gave us incredibly helpful feedback on how we can improve this book. I'd like to share a few examples of 3 key ways to promote community empowerment for women's health, highlighted in the field testing experiences that I had in Oaxaca, Mexico, where I lived with my family and worked during a sabbatical year in 2008. The 3 strategies to achieve this second principle include raising awareness about gender, race, and class inequality, organizing and mobilizing communities, and third, using a rights-based approach to grassroots advocacy. I'll cover these one at a time as well. We use the first strategy to raise awareness about race, class, and gender inequality and their impact on women's health in a series of wonderful participatory activities. In one community workshop, we told the story of a young Indigenous woman's unplanned pregnancy, and we used a problem tree. Has anyone ever seen this concept, this paradigm? The problem's in the middle, and then you're looking for the different root causes, and the solutions are at the top of the tree, a problem tree. It's kind of one of our core pedagogical methods. So we used a problem tree to guide a group discussion about the complex barriers to family planning that poor Indigenous women face. This helped this group see how gender, race, and class inequality work together as a system to marginalize people and deny them their basic human rights, and how they interact with other root causes or social determinants of health to undermine women's health. We explored differences in power and resources between men and women and the impact of these differences on their health. Reflection on this common experience laid the foundation for an activity called the Balance of Burdens, meant to raise awareness about gender equity and how poor Indigenous women bear even greater burden than men. This activity allowed us to discuss how other groups could also experience this burden even more. For example, people with disabilities, sex workers, members of the LGBT community, immigrants, and youth can suffer even greater health consequences because of their lack of power and marginalized status. So in this activity, these are 2 bags of beans, and as people talk about the different burdens that people experience, if you're young or an immigrant or a sex worker, then you add beans to the side, whether it's a woman or a man, and it's a very clear process of realizing how gender equity affects health and how those other dimensions of marginalization make it even harder to be healthy. Some of the men in the workshop said it was amazing and that for the first time they really saw how gender inequity impacted health. And the other thing was incredible, or impacted women's health, but they also saw how machismo affected men's physical and emotional health. And even most important was that they saw that change was possible. This wonderful older Indigenous woman stood up and said for the first time she really understood the concept of gender inequity, and that she was going to go home and talk to her children, her girls and boys, and ask them to get out and talk with other people in the community and work for change. It was incredible to have these experiences and see the lights going on for people and have them understand the importance of gender equity and how in so many dimensions it affects women's health. These were just some of the things that they came up with. If we promote gender equity, it will help women learn about their health and improve access to health resources. Promoting gender equity would help decrease early marriage, and that is, very common in poor communities around the world, in particular in these rural areas of Guatemala. Girls will often be married, when they're 15 or 16. It will decrease unplanned pregnancies, sexually transmitted infections, gender-based violence, and ultimately decrease maternal and infant mortality. And this all comes through this process of people reflecting and coming up with their ideas. The second way to promote community empowerment for health is to organize and mobilize communities for women's sexual and reproductive health rights. In another field testing workshop, in a rural community, we used activities and strategies that have been developed by groups in other parts of Mexico to help women feel comfortable talking about sexuality and to learn about their sexual and reproductive health rights. The most popular game was Sexy Bingo. This game brought incredible laughter, gales of laughter to people who were playing for the first time and talking about these words that, were never mentioned and were really considered taboo. We showed this group how this activity of bingo had been adapted from another bingo game used by another grassroots group in a region of Mexico, and they were using bingo to teach people about women's human rights. We also used what's called the Journey to Health board game to teach people the steps involved in community organizing and mobilization. We were delighted to hear that one of the youths was already using this strategy of social audits. Does anyone know what a social audit is? So they would go to their local clinic, and this was a young woman, she was about 16, and she would go to the clinic and ask for condoms and birth control, and then assess how friendly that clinic was to young people in the community. And then she did this project of power mapping, where she worked with other youth to map who were the important leaders in the community, who she had to work with, or the young people had to work with, to make that clinic more youth-friendly. And so she organized this whole group together, and ultimately, because of that kind of power mapping and strategizing, they were able to change that clinic to be much more friendly to young people. At this point, that clinic has special hours that are designated just for youth. They have low-cost condoms, and they have weekly youth-focused health talks. And what was really incredible in all of these workshops, because we almost always gave them a copy of Where Women Have No Doctor at the end of it, was the sense of the ripple effect that happens when each one of these young Indigenous leaders would go back to their community where there could be 100 or 200 people, and they would share that information, do that kind of consciousness raising and organizing and mobilizing, and just sense that tremendous ripple effect that that kind of outreach has. The third way to promote community empowerment for women's health is to use a rights-based approach to grassroots advocacy. This approach is strategic to achieving health equity for women of all ages. In our field testing process, we discovered the power of stories using human rights advocacy to promote community action. In one workshop, we read a wonderful story about a teacher named Abdullah, who was a man in Tanzania who was outraged when a 13-year-old girl died in his community because she didn't have access to free emergency pregnancy care. She had a delayed, complicated delivery and couldn't get the ambulance to get care. So he studied international human rights law, and he started to organize regionally and then nationally for the right to safe pregnancy care. And his efforts were amazing. He joined with some other national advocates, and over the course of several years, they actually changed the law in Tanzania that gives every woman the right to free pregnancy care. So we were sharing this story in this workshop in Oaxaca, and one woman said, if one man in a village in Africa can do this, why can't we do this here in Oaxaca? And so since then, a number of these young people have joined a regional safe motherhood advocacy movement in southern Mexico. So that tremendous and wonderful sharing of ideas. These community leaders' resolve was strengthened when they learned of the tremendous rights-based advocacy work being done by health activists in Peru. This story from Peru provides the conceptual framework for promoting community empowerment for health and health actions for women. So we use this really to narrate the whole process of community organizing. That's how we start the book. It takes place in the remote community, it's an indigenous village, of Vilcashuaman, where people became mobilized after the death of a woman and her baby. In response to this tragedy, community women from Vilcashuaman gathered to reflect on their own experiences and to discuss the reasons why this happens so often in their region. They analyzed the root causes of this problem, and like others working on the issue of maternal mortality in Peru, they found that in addition to poverty, experiences of gender and ethnic discrimination prevented many poor indigenous women from getting the care they needed. These women reached out to allies, including women and men, learned about their human rights, and planned for and took action. This group had successes as well as many setbacks along the way in their efforts to improve their local health services. With each step they took, they evaluated their work, gained insight from the accomplishments as well as their failures, and they had many along the way. Over time, women and men from surrounding communities near Vilcashuaman used this iterative process of taking action and reflection and action to engage the local health workers and politicians or local leaders to create a safe motherhood house right next to their town's clinic. After several years of organizing and mobilizing support and resources, these community members created a place where pregnant women and their families could stay and safely give birth in a setting that respected the women and the Quechua culture. Human rights advocates from Peru and other countries learned of these village women's efforts and used their testimonies as part of a rights-based advocacy strategy to promote safe motherhood. And they actually went there and took their testimonies and used those in a report that was presented to the United Nations and was the foundation for the first UN resolution to promote safe motherhood. In the last decade, the synergy between these grassroots, national, and global efforts has helped to transform health services in Vilcashuaman and hundreds of other communities in Peru. Inspired by the story of Vilcashuaman, these communities have mobilized resources, expanded health services, and every one of them has created a culturally responsive, safe motherhood house. This powerful experience of people working together to raise awareness and mobilize others using a rights-based strategy to improving health services for Indigenous women brought dramatic results. Maternal mortality in Vilcashuaman and the poor communities in that region has decreased by 50%. As I saw in these field testing workshops in Oaxaca, there is tremendous power in the cross-fertilization of ideas and understanding of human rights that happens when people from diverse contexts in the global South hear each other's stories. The experiences I had in Oaxaca were echoed in the feedback that we received from grassroots groups around the world who helped us field test activities and content for health actions for women. After I conclude, I'd like to share a short video that highlights some of these global experiences. When we imagine these activities, discussions, and action being taken in diverse social, cultural, and political contexts, we feel hope that change is possible. This remarkable global grassroots collaboration to create health actions for women has yielded a resource that responds to the needs that the Guatemalan midwives expressed many years before. A resource that helps people understand how the toxic triad of gender, economic, and racial inequality undermines everyone's health, and how working for change benefits women and men of all ages in our communities. We hope that health actions for women will help people come together to analyze the root causes of their health problems and provide tools to build solidarity with others to mobilize for change. All this work, inspired by these two principles, to make health information accessible and to promote community empowerment for women's health, has been grounded in a commitment to partnership, equity, and social justice. The people who have guided this work are women and men from the communities most affected by the health problems being addressed. These lessons learned from and for resource-poor communities around the world support action to promote the health and rights of women of all ages in the global South. We invite you to join us. And I'm just going to talk briefly about opportunities that we have in Central Texas, both some of the work going on here and work with Hesperian. And this is just a brief reflection on what community participatory research is about and how it draws on inspiration from the global South. So the process that I described of popular education, of looking at your experience, of reflecting and analyzing, and then taking action is very much the same approach that we use in community-based participatory research. And so Dr. Kim and I are co-teaching this wonderful graduate seminar, and this is our class, and some of the community groups. We have 6 community organizations that are involved with the students, and we have formed teams, and the community organizations identify the problems, and then the teams of students work with the organizations to focus, try to understand what the root causes are, and then make a proposal either for a research project or for some kind of an intervention. So it's really that same kind of iterative and wonderful approach that draws inspiration from the global South, meaning from, in this case, the experience of popular education in Latin America. One of the other things that I mentioned a lot was the use of community health workers, and this was an initiative that I was involved in about a decade ago in Austin, the East Austin Community Health Promoters Project. And we had folks who were from the community who were doing outreach to help prevent childhood obesity and also help people who had diabetes overcome all the different kinds of social and economic barriers to their own care. And now there are many other, I'm sure you've heard this, there are many other community health worker projects going on in Central Texas. Some are focused on diabetes, some are focused on improving birth outcomes for women of color. There are a number, and there would be opportunities for students to get involved in that. And I really want to encourage any students that are interested in doing any collaboration with Hesperian. There is need for help if you're just sitting here in Austin, Texas, or if you wanted to be involved in global health opportunities. As you saw, we have partners all over the world who've helped us field test. And this new book, Health Actions for Women, we're very interested in having students get placed with some of our global partners and actually help us do research on the impact. How are these books being adapted in diverse contexts? How are they being modified? What kind of impact do they have? What kind of change? And so any students that were interested in that would be wonderful. We are also working to create a transmedia resource, which is on our website, called the Women's Health Forum, where groups around the world who are doing innovative work would take photographs or short videos of what they're doing and then be able to share that in this website that could be accessed by people all over the world. The root cause tree that I showed you about family planning is something that we would love to turn into an animated pedagogical tool that could be used online. So you would be able to click on a button and see the roots, explore the different root causes. You'd be able to click on leaves and find solutions and action being taken in different contexts around different problems. So if that sparks any ideas, please see me. And then finally, we have that phone app, but we're working on another one right now on family planning, and there are many other ideas that we have of new phone apps. So helping develop the phone app or helping field test the phone app, that would be a wonderful project if students are interested. And as promised, I want to just share a short video, 3-minute video, which shows some of the field testing experiences. Should we turn off the light?
मेरा नाम साजिदा है और मैं स्टेप एनजीओ में काम करती हूँ। गरीब बंदा ने वैसे भी बेचारा बेज़बान होता है ते औरत ने और बेज़बान
ਅਸੀਂ ਇਹਨਾਂ ਮਸਾਇਲ ਨਾਲ ਲੈ ਕੇ ਤੇ ਆਪਣੇ ਜਿਹੜੇ ਭੈਣਾਂ ਨੇ ਸਾਡੀ ਬੇਟੀਆਂ ਨੇ ਮਾਵਾਂ ਨੇ ਸਭ ਦੇ ਮਸਾਇਲ ਨੂੰ ਇਸ ਮਾਸ਼ਰੇ ਦੇ ਵਿੱਚ ਇਸ ਚੱਕਰ ਨੂੰ ਖਤਮ ਕਰਨਾ ਅਸੀਂ ਇਸ ਚੱਕਰ ਨੂੰ ਤੋੜਨਾ ਔਰ ਇਹ ਅਸੀਂ ਕਿਵੇਂ ਤੋੜ ਸਕਦੇ ਹਾਂ ਹਿੰਮਤ ਕਰਕੇ ਅਸੀਂ ਆਪਣੀ ਆਵਾਜ਼ ਨੂੰ ਬੁਲੰਦ ਕਰਕੇ ਅਸੀਂ ਦੂਸਰਿਆਂ ਦਾ ਸਾਥ ਦੇ ਕੇ ਅਸੀਂ ਆਪਣਾ ਵਕਤ ਦੇ ਕੇ ਕਿਸੇ ਵੀ ਤਰੀਕੇ ਨਾਲ ਅਸੀਂ ਇਸ ਮਸਾਇਲ ਨੂੰ ਨਾ ਮਸਾਇਲ
These type of activities have stimulated the group participants' thoughts and have brainstormed their minds to different types of violence and their forms. The issues like emotional and economic violence need to be discussed and promoted in the book because these issues are important to us. The types of information presented in the book have helped the group to understand deeply what violence means and how it can have an influence in one person's mental, physical, and economic and emotional balance.
The questions made the activity even more interactive. First, to build up their confidence, I let the girls talk about what affects them. Then they shared ideas with the boys. The young girls were a little shy to talk about some issues compared to the boys, but then they opened up and began expressing their views and concerns. That day, the young women and girls had an opportunity to speak with one voice against traditional beliefs, unhealthy conditions, and other practices that they experienced.
I have a few books if anyone wants to look at them, just to see what's inside. Anybody want to come help us? Well, thank you all. Lovely to be with you. And I think, there's a little something outside? Okay. Good. Please see me if you're interested in working in any way. Thank you.